What's that, Rodrigo? You're tired of hanging out with me while I draw this and just hear me mutter all day long? You want to bring some real people into this process? Well, here we go. Here goes nothing, Rodrigo. Let's try it out. Soon to make a video about nerve injury. And this is grounded in real situations. Like, for example, recently I had a patient with a fractured ulna close to the elbow and some subsequent injury and inflammation to the ulnar nerve. So the gist of the video is that we really want to understand what's happening in the ecology of a nerve when it's under mechanical and inflammatory stress. And to do that well means that you can somewhat predict the timeline of healing for that nerve injury, if healing is in the cards. And you can also maximize the safety of working with this system. How can you reduce stress on this ecology while the healing process is happening? That's a crucial question for anybody in movement rehabilitation, in manual therapy. So that's what the video is going to be about. And we begin from the macro. So we're going to start with this kind of palmar view of the forearm. In this case, we're talking about an ulnar nerve as it courses around the proximal ulna. Encounters some stress as it has to bend around that ulna. And indeed, while there's a surgical healing process going on, there's a little more inflammation here. In the adjacent median nerve, in this case, it's healthy. This is a normal multifascicular nerve in the body, and it's ensheathed in a mesoneurium. It's got nested tubes of dense, irregular collagen suffused with blood supply and indeed nerve supply, the intrinsic nerve supply there. That nerve supply and blood supply and fascial ensheathment whittles itself down to the smallest scale. How big a scale? Well, it's a fraction of the size of the average human hair, but not an unimaginable fraction. So you're talking an average human hair, about 80 microns thick. We're getting down to the 20 micron level for these tubes of endoneurial fascia here that enclose the conducting fiber. Now, every conducting fiber in the body, let's say axons, are ensheathed in a Schwann cell. And the shape of this determines a lot about the healing potential and the conduction speed and the type of receptors at the end. So what we call myelinated axons have these Schwann cells that wrap around thickly or thinly. And then what we call unmyelinated axons are actually still embedded in a Schwann cell. It's just more of a group ride here that we call a Remac bundle. So these are slow and small fibers, useful for lots of innervation of things that don't require speed to get back to the central nervous system. This is all about motor and sensory stuff that needs to get where it's going fast, hence the insulation and the large diameter of those axons. Now, the crucial unit of the ecology of a nerve, both for its normal function day-to-day, motor and sensory function, but also for its capacity for healing, is the blood-nerve barrier. Okay, so if we were to take a slice of this endoneurium and look at it head on, what you see is that the nutrients and metabolites and waste products, etc., that need to get into and out of the axon and Schwann cells environment have to do so through the endoneurium and the fascia sites, the fiber sites that live in that endoneurium. So it's just like the blood-brain barrier. These local cells and the matrix are sort of filtering and playing doorman for the endoneurial environment, the Schwann cell and the axons. So how fast does this heal? Can this heal? Is partially dependent on the resources available to that healing axon. This is why it's such a problem to have metabolic disorders or peripheral blood flow issues, or indeed to not eat enough, because you need lots of oxygen and glucose to be a nerve. This is an energy-intensive process. That's why there's such a rich blood supply. And long before you're worried about mechanical injury to a nerve, nerves can experience metabolic stress. And that explains a whole lot of what goes wrong with nerves long before you get to injury. They're actually quite robust. But the needs of this nerve for oxygen, glucose, ATP, these are a daily struggle because nerves are expensive for the body. Now, the other thing to look at with this view of the endoneurium is this basement membrane, because it's here where the growth factors, the trophic factors live that guide the regrowth of both Schwann cells and axons. Meaning that if there's some kind of rupture or breakage in this conduction, where it's going to heal is going to be guided by the interior of these tubes. Okay? And so as long as the tubes are intact, there's hope for regrowth. That's the kind of basic story. So now let's talk about injury, as in the case of my patient with the elbow proximal ulnar fracture here. The first and most common thing we encounter at various levels of severity is neuroinflammation. That's to say a bloodshot. Literally, you can see pictures of a nerve, and I'll show this in the video, where the vessels that accompany the nerve and penetrate the nerve are proliferated, swollen, lots more blood supply coming here, and lots more mechanosensitivity. So whenever a nerve is feeling, and you can feel this in yourself if you palpate your ulnar nerve for a little while or any other nerve, you'll feel kind of a bruisey, boggy discomfort. That's the exudate of an inflamed nerve sensitizing the tissue. So your conduction is intact in many cases. There's no disruption to the axons. However, there's lots of mechanical sensitivity and lots of inflammation being generated by the nerve under that kind of stress. This is common. This goes up and down. This is not necessarily a bad thing, right? Blood flow, blood supply can be a good thing if you're trying to heal a nerve. Now, under enough mechanical stress or under long enough metabolic deprivation, you can have problems with this environment up here, this key ecology of the interior of the nerve. And it kind of exists on a spectrum. This spectrum goes from moderate to severe, and the prognosis for healing changes depending on which of these you've got. And the best way to diagnose between these is a conduction test, of course, in the context of a good clinical history. So if you suspect these, definitely time to check out a visit with a neurologist or someone else capable of doing a diagnosis. When there is temporary disruption of the support structures around the axon, the Schwann cell is disrupted, the intrinsic blood supply is ruptured or damaged, such that there is no more insulation or support around a majority of axons, you have what's called neuropraxia. It's a breakdown of the support system and thus the conduction, and you can have motor loss, you can have sensory loss, all kinds of stuff here. But the tubes are intact and the axons are intact. That's the story with neuropraxia, and that is good news. It means that on the order of weeks, you will probably recover function, assuming you have enough resources, again, glucose, oxygen, etc., to facilitate the regrowth of these Schwann cells within their tubes. Okay, so that's the classic neuropraxia. As you get more stress on the nerve, and we're talking quite a bit of mechanical stress required to actually damage a nerve, you can begin to experience the discontinuity of axons, the actual rupture of conducting fibers. That's what we call axonogmesis, and that means a longer healing timeline, because indeed, now that the axon is ruptured, it's going to take the regrowth of axons with the right resources all the way from the cell body sometimes through this endoneurium to whatever target tissue. That takes months, right? So we're talking a good number of months to fully regrow and recover function in that nerve. But functional recovery is likely because you still have those intact tubes of endoneurium, the intact fascial environment, and that basement membrane is still guiding the regrowth. It's when you get to damage sufficient that it ruptures the endoneurium, that's where regrowth may not be possible. That's where these flailing axons and Schwann cells can't actually find their distal pair, and you no longer have, at least for a subset of those fibers, the ability to regain function. So you might have experienced this if you've cut yourself with a kitchen knife and now you have this permanent numb spot on your pinky. You might also experience this falling off a motorcycle or having surgery or something like that. When there's a severe enough injury where conduction is lost, where continuity is suspected broken in the connective tissues of the nerve. That's when, if you really need to recover function, it's useful to consider peripheral nerve surgery or other strategies for helping axons regrow through a functional tube, right? They will try to regrow with sufficient nerve growth factor, but if they regrow into a tangle of broken fascia here, broken collagen, you're likely to get a neuroma, at least with sensory nerves, as opposed to a functional nerve. So here's where considering a nerve graft or a nerve, some kind of other peripheral nerve surgery might be helpful. So this has turned into kind of a lengthy preview. What I hope to do with the video is to show you more actual examples, more visuals, and not just this schema. But I hope you enjoyed the discussion. Rodrigo, did I do a good job? Are you tired of hearing me talk yet again? We have an acrimonious collegial relationship, but it works. And I hope, I don't hope the same is true for you. I hope you enjoyed this video, and I wish you a good week with yourself and the people in your care. Bye-bye.